At the heart of what we do is exploring limitless possibilities to enrich lives all over the world. Life is precious, and we are in the business of cherishing every precious heartbeat. Every day brings a new reason to better our lives. Something to learn, something to laugh and enjoy, something to dream. For as long as there's a dream, there's hope, and as long as there's hope, there's joy in living. Reasons for us to keep every heart happy and healthy. Helping us in our endeavor are the many interventional cardiovascular solutions that we create. At our state-of-the-art facilities, we make our stents and catheters, wires and needles, German excellence and Indian innovation backed by credible research. With the unmatched advantage of being the only company with clinical trials data spanning over 10 years for efficacy and safety. And a one-of-its-kind partnership with the German Heart Center, renowned for its pioneering advancements in cardiovascular technologies. It's not surprising we have over 5,000 satisfied clients and 1 million smiling patients in over 50 countries around the world. We trust good things happen when you follow your heart, because there's an ocean of opportunities to discover. And our journey has just begun. Translumina, exploring limitless possibilities of life.
Good afternoon, Maharashtra. So Translumina is back with BIC 2020 Maharashtra chapter. The first session is India's journey with shockwave lithotripsy. But first of all, I would like to tell everybody a very happy Independence Day. So here we have Dr. C.N. Makle as our moderator. He is the director and professor at Ruby Hall Clinic, Pune, and he has 30 plus publications to his credit and has performed more than 40,000 interventions in his long and illustrious career. So I would request Dr. C.N. Makle to take over and start the session, please.
Hi, good evening, everybody. Greetings of the Independence Day, and I hope everybody is safe at home. Today we are going through the journey, India's journey of shockwave. I think the shockwave was introduced in our country about more than a year back, and everybody has got some experience of shockwave intravascular lithotripsy. It has been an amazing technology. So to discuss this and share experiences, we are here today on this virtual platform. With me, I have got Dr. Keith Dawkins, who is the Chief Medical Officer with IVL Technologies with lithotripsy. Then Dr. Kirti Punamia from Rich Candy Hospital, known all over the world. And with others, the panelists are Dr. Suresh Vijan from Lilavati, Dr. Sunil Vani, Dr. Milind Kharche, and Dr. Ravikant Patil. And they will be presenting their cases as we go along and sharing the experiences, including Dr. Rohan Enchwar. So without wasting much of the time, because we have already started, we have been already delayed by 6 minutes. So I request Dr. Keith Dawkins to give his presentation. May I request Dr. Keith Dawkins, please.
Thank you very much, and it's a pleasure for me to be talking to colleagues and friends in India on this special day, Independence Day. And over the next few minutes, I will put into perspective intravascular lithotripsy, IVL, and then we'll see some cases that you've undertaken in India. You all know that cardiovascular calcification is becoming more prevalent due to smoking, diabetes, which is a big issue in your country, chronic renal disease, and an aging population. And you also know that PCI patients is more complex, and the outcomes may be negatively affected by conventional PCI. So it's clear that new technologies are required to help you in your daily practice. It really doesn't matter which vascular bed you look at, they all have calcification. So of the approximately 3.5 million coronary artery procedures undertaken every year in the world, about a third of them have calcium. And obviously TAVI, all aortic valves are calcified. And then there are other groups in the peripheral vascular space, including large bore access, iliac, FEMPOP, and below the knee. All require some sort of help. And you know, of course, that outcomes in PCI with calcium are negatively affected by calcium. So these are data from Philippe Généreux, Horizons and Acuity, almost 7,000 patients. And calcium is graded yellow, blue, or red. And you can see that all outcomes are less favorable with calcified coronary arteries, including death, cardiac death, MI, TLR, and overall MACE. The coronary artery calcification is an independent predictor of not being able to optimally implant a DES. The greater the arc length and thickness of calcium, the greater the likelihood of stent under expansion. And asymmetrical stent expansion is seen in about half the patients with calcified lesions. And of course, stent under expansion is associated with an increased risk of ischemic events at 1 year, including stent thrombosis. So many of you will have been aware or used the Shockwave intravascular lithotripsy IVL system, which of course was based originally on the use of lithotripsy to deal with renal stones. It's a very simple device. It has a generator on the left, a connector cable in the middle, and the catheter on the right. The catheter will run over any 014 guide wire. Simple magnetic connections, and it's push button activated. So expanding and collapsing vapor bubbles create a short burst of sonic pressure waves. And these travel through the vessel tissue with an effective pressure of about 50 atmospheres, but for a very short time. And so you get a localized field effect that affects hard tissue, particularly calcium, but leaves soft tissue, the connective tissue and so on in the vessel wall untouched. You inflate the balloon here just to 4 atmospheres, and that just causes apposition of the lithotripsy balloon against the arterial wall. There are 3 products available, C2, S4, and M5, and the number indicates the number of emitters in the device. For coronary use, C2 is the device, and for peripheral use, S4 and M5. So the coronary device releases 80 pulses of energy, comes in 2.5 to 4 millimeter diameters, and just one length of 12 millimeters. So if you have a long lesion, you need to move the balloon up or down the vessel a little. 014 guide wire, 6 French compatible for coronary. The S4 is for below the knee use, and the M5 is for large bore access, iliac, CFA, SFA. So in the coronary program, we have 4 studies. The proof of concept study, which was completed and published, small study, single arm, 60 patients. This was built on by CAD2, which was double the size, similar protocol. And the pivotal US IDE trial, CAD3, which is being completed, 384 patients, 100 patients with OCT substudy. And these data will be presented as a late-breaking trial by Dean Keriakis at TCT Connect in October. And Disrupt CAD4, which is the Japanese approval study, also completed 72 patients. Obviously, I can't share with you yet the CAD3 results, which will be presented the month after next. But in CAD2, with a similar protocol, the clinical success was very high at 94.2, angiographic success 100. About half the patients had pre-DIL, and the residual stenosis was small, less than 10, acute gain of 1.63, and a very good safety profile. This is a very safe device. No abnormal outcomes in 98.3%. No perforation, abrupt closure, slow or no reflow. The only complications were a small amount of in-hospital MACE due to non-Q8 myocardial infarction. So here's a case from CAD2. This is the proximal vessel, maximum calcification in the distal vessel, and these are paired OCT images, pre-PCI and post-PCI, and you see there's a dramatic increase in lumen from 3.51 to 7.32, and it's obvious to you, I'm sure, the point of the calcium fracture. At the point of maximum calcification with calcium almost all around the vessel, similar calcium fracture, and the lumen goes from 2.95 to 8.78. And the distal vessel, a similar appearance, 3.81 to 8.91. Some of you do peripheral treatment, and we have a similar collection of studies for the periphery. PAD 1, 2, below the knee, PAD 3, and the PAD 3 registry. And the PAD 3 randomized trial, which is a post-market trial, 306 patients randomized, including DCB, will be presented in November at the VIVA meeting. There was published earlier this year a meta-analysis of IVL in peripheral disease. And you can see here 357 lesions, tightly stenosed, 78.8% stenosed, down to 28.9% post-IVL. And the final was 23.6%. Highly effective in all peripheral vascular beds. These data were core lab adjudicated. And some of you will do TAVI, and you will from time to time have difficulty with access. And large bore access, both for TAVI and Impeller, it can be facilitated with IVL. Here's a patient with bilateral severe iliac disease, almost interrupting the distal aorta, treated with 2 7mm IVL balloons, and very nice result. And Carlo Di Mario presented a series of 42 patients undergoing IVL prior to TAVI with no complications and very good results. So although the company has only been here for a short time, we're already developing a large amount of literature in a variety of different types of patients, types of anatomy, and different vascular beds. The last live meeting I went to before the COVID shutdown was India Live in 2020 in Delhi. And these are a few pictures I took. There was a lot of interest in IVL, as you know, a lot of good live cases, a lot of good discussion and presentations. And I'll hope that the next India Live meeting in Chennai next year will take place if we've all got ourselves safely through COVID. So in summary, the prevalence of cardiovascular calcification is increasing. Vessel calcification leads to adverse outcomes when treated with conventional PCI. Shockwave IVL is a transformative platform now available in more than 45 countries worldwide. Very simple, short learning curve, efficacious, safe, predictable, reproducible, and applicable to all treated vascular beds. It's an adjunct to traditional technology, including simple balloon angioplasty, drug-coated balloons, stents, and some of you would have used it in combination with Rota. In the US, IVL is approved for the treatment of peripheral artery disease, including large bore access. In Europe and other geographies, including India, the C2 IVL device received CE mark in May 2017 for the treatment of complex calcific coronary disease. And we're looking at the use of IVL in a number of other treatment options, including the treatment of valvular disease and so on. So more to come, and certainly more devices are in development. Thank you very much for your attention.
Yeah, thank you very much, Dr. Keith Dawkins. It was a wonderful presentation and giving the insights of intravascular lithotripsy. The biggest thing what I really admire, one was it is one of the devices where there is a 0% perforation or 0% death, which is associated with some numbers are always associated with rotablation or other devices. So it is really safe, as we could see from these trials. The other thing is, you said that there is an increase in prevalence of the calcium. I will sort of differ here. The calcium was very much there, but we were shying away to do those type of cases, and we were referring more for the surgical, or we were going for the rotablation. Now here we have got another technology, another device in our armamentarium to go for the address that issue. Now I'll request Dr. Kirti Punamia from the Bridge Candy Hospital. Kirti doesn't need any introduction. He's known all over the, not only country, but across the globe. And he's a Rota master. So he has to now change over to lithotriptan. Kirti, please.
Thank you. Thank you, Dr. Makle. That's a great introduction, Keith. And I'm just going to try and see how I can place this. Yeah, can you see my slides?
Yeah. Can you go on a full screen, please?
Yeah, I am going to do that. Is that good?
Yeah, correct. Absolutely.
Great. One moment. Get me this out of here. Great. So we've been fighting a battle with calcified lesions for a very long time. And along the path, many a times we've had these little tools come our way. And the last most effective tool that I looked at for calcified lesions was the rotablator, and it has stayed with us for the many years. Here is our little experience from our previous years with calcium. A calcified left main, bilateral, both LAD and circumflex, you can say. So what we did was we did a rotational atherectomy into the LAD as well as the circumflex, and you can see that there was a calcified lesion with very large reverberations that you can see. If you can give me just 1 minute, my battery is at 1%. Didn't realize. Can I just take a 30-second break to put my charger on? Just a 30-second, okay?
Sure, sir.
Yeah, will do.
Sorry. Okay, so here we are. Sorry about that. So here we used a single burr. It was often just a 1.5 burr. We chose a random balloon, which was almost always in the left main context. It was a 3O flextome. And then we chose stents according to the intravascular ultrasound landing zones. We've followed the DK crushes, we've done culottes and various techniques. And you can see that the angiographic result of these was very good, as you can see in this angiogram there. But what we find on the intravascular ultrasound, and those images to the far right, the top is the proximal LAD, the bottom is the ostium of the circumflex. And for having put in 3.5 and 4O stents in those arteries, we had expected MSAs, cross-sectional areas for the stents in the range of 9.6 and 9.6 in each of those branches. What we got was 5.8 and 5.4. That is severely under-expanded stents. These are often not recognized on the angiography. Two, we also recognize, if you look at the bottom image, you can see there's plaque prolapse and there's serious distortion in terms of oblongations of the stent, especially in the circumflex ostium. So the lesion preparation was not adequate. this patient went for a CABG at the end of 8 months. When he kind of taking the story forward, this was a lesion later, and based on that, we decided that we'd do a little more aggressive, we'll have a little more aggressive strategy. So what we did was, instead of stopping at a 1.5 burr, we went from 1.5 to 1.75, or in some cases like this one, we went up to 2.0 burr and did a rotational atherectomy with a 2.0 in the LAD and the circumflex ostium. Upsizing the burr with these images, you can see, these are the images. You can see that even in the core images, which is in the distal left main and the confluence and the ostia of the circumflex and the LAD, you can see large chunks of calcium even there and sheets of calcium. But this kind of brought us a little bit of advantage, and we were able to achieve adequate expansion of our stents. And in this kind of, which is a representative of this strategy, you can see that we started achieving stent expansions to the 95% of what we expected based on the stent size that we chose. And so here we had a great angiographic result and a great IVUS result. And these patients ended up doing well. The problem was this ring of calcium, which was deeply located. And you can see that with the OCT as well as you can see that with the IVUS. And often enough, when you see these reverberations after rotational atherectomy, it often points to a thick layer of calcium. It's just the inside is smooth, so it reverberates behind on the ultrasound. And it was absolutely important to crack this. When we look at our data, we realize that very often, in spite of these aggressive techniques, when you actually take a 3.5 stent or a 4.0 stent in these locations, you're not getting an 8.5 or 11, which is the optimal MSA. You're often enough getting a less than 7.5 or less than 10 for the kind of sizes that you're using. And those happened in almost 15 to 20% of our patients, despite of this aggressive and very aggressive rotablation approach and sizing the FlexStome balloons. And at this point in time, we also started going to very high pressures on the FlexStome. Even though it's outside the IFU, we ended up routinely going to 16 and 18 atmospheres. These patients who did not expand had higher rates of restenosis. Some came back with ostial circumflex, or some came back with ostial LAD lesions. Some came back with proximal left main lesions. On the other hand, we had these very stubborn plaques, like in this one, which was the ostial left main plaque, awkwardly situated. And you can see the IVUS images. No single image is representative of the complete circumferential calcium that you see in these patients. But when you look at the IVUS image and you go across, you can then recognize the ring of calcium at the ostium if you compute this image on these multiple frames that go across. We did a 2.0 burr, we did a 2.0 rotational atherectomy for this patient, and following a 2.0 rotational atherectomy, we used a 3.5, then 4, and this is a representation image of a 4.5 NC balloon at 24 atmospheres, and it still would not crack. Ultrasound showed us that the distal reference segment was around 5.3 millimeters, and therefore we went with a 5.0 balloon at 20 atmospheres, and it eventually gave way. We were lucky. We were just plain simple lucky. We put in our stents, got a great result. But we have to learn to make these procedures predictable. It cannot be that we took chances and we take chances, because if there was a rupture, this could have been catastrophic, and we could have actually extended dissections into the aorta and even compromising the aortic valve at times. So all this long, until 2018, we had this aggressive PTRA approach, or if the lumen allowed us, we would put in an NC balloon directly, or an OPN scoring, or a FlexStome, or Wolverine as it were. And then this would be an aggressive rotational atherectomy or an ablative technology in India, followed by one of these technologies, and all these technologies were based on high pressure balloon dilatations. And those were the limitations. On the left, the size of the burr was a limitation. And on the right, every of these technologies required a sustained high pressure to achieve our results. What happens? This indicates that there is a huge gap with unmet needs in this space. This often came at a very high price of perforations that you can see on the left, you can see stuck and stalled burrs with aggressive approaches and taking up these very calcified, challenging calcified lesions. And this is a stuck burr from a colleague of mine from almost around 6 years ago. And this is a 1.25 burr. We've known it up since for a long time. But we often saw these major problems. On the right side is a dreaded slow flow in one of my patients, which led to mortality. And the price we pay for aggressive rotational atherectomy, even though very rare and very small in number, it's a definite price we pay by these complications, which are serious and often associated with mortality. When you look at ACS in these elderly patients, and this is an 86-year-old lady who came with ACS, left ventricular ejection fraction of 30%, heavily calcified LAD in the segment 7 and 8 on the Syntex chart, with a circumflex segment 11 with very calcified lesions which are discrete. How do we approach these patients now? So the first is after the initial rotational atherectomy, this is the IVUS run. Most of these will not allow the IVUS run to be performed prior to the rotational atherectomy. So once we have the rotational atherectomy 1.5 going in, we have an IVUS run, and that gives us the lay of the land. And here you can see right around the image 2, which is the B3 image, you can see around that cross section, you can see calcium on either side with a huge amount of dropouts and shadows at that point. This image purely just tells us the landing zones, and it refers to what is going to be a stent sizing for this case. But actually, how do we plan this? Oh, sorry, some slides which are completely mixed. Just a minute. God. Okay, I'll come back to this case. There's some slides missing. Sorry about that. I'll come back to this case again. So with this, this is a 61-year-old gentleman who came with exertion-related shortness of breath on the echo, good LV function, EF 55, CAG showed triple vessel, long calcified lesions, LAD 80%, OM 80%, and multivessel disease. Should we go for a multivessel PCI or CABG? That was a non-dominant right coronary artery at the right. So what we did was we did an FFR for that distal circumflex, and it was negative. For that OM, that was negative. And the FFR, the resting PDPA was 7.8, and the FFR was 0.45 for the LAD in that segment there. Of course, we needed to sort this out. So you can see the struggle that our microcatheter faces in advancing over the wire. And then with a little bit of rotation and luck, we got that going. Following a 1.5 rotational atherectomy, this is our angiography, and it shows that there is significant disease happening there, which we need to address. At this point in time, our area which is going to give us trouble is approximately just after that septal branch until just after that second diagonal branch. Here is that stubborn lesion, which at 18 atmospheres, based on the IVUS images, we actually go and size these arteries. And here you can see at 18 atmospheres, it wouldn't give way. This is where so what is that lesion about? This is that lesion just next to that septal branch. And if you look at this IVUS run, you can see, this is what we see on the echo, on the ultrasound. It's a concentric calcium with huge layers of calcium, and it ends just at that septal branch. These kind of echo images often tell us that we need to now get onto IVL because it's concentric calcium. This is our IVL, 3.0 by 12, based on the echo size of the reference vessel and the lumen that we want to achieve in that area. And once we had that, the entire length received about 30 to 40 pulses at 2 locations, and we got a great result. So once that was done, 1.5 rotational atherectomy, a high pressure balloon dilatation at 18, an IVL balloon 3.0 with what I just mentioned, and 3 DSs, Guidezilla assist deployment of those stents. This was the final result. At this stage, the IVUS does not pass because even the IVUS catheter sometimes would have difficulty in these little minor tortuosities, and the thing is never to push it out, push it in, because you might fracture those catheters on the way back. We repeated an FFR, and we'd actually improved the FFR to 0.87. So there is a role for doing a functional FFR at the end of these long stented lesions to kind of have a goalpost in which we kind of define success. For us, anything less than 0.85 would have meant more dilatations subsequently, but 0.87 is quite acceptable to us. The 61-year-old gentleman with a calcium score of 1274, ex-smoker, hypertensive, diabetic, with a strong family history. You can see all his vitals there with a 31% risk for 10-year event for cardiovascular events. Came here with a lesion such as this, a distal left main, which was tight, going into an extremely tight and a critically stenosed circumflex, which gave rise to a large early OM, almost behaving like a trifurcation. CT scan, we just get a CT calcium score and a calcium lay of the land done for these patients. And this is what the CT tells me. The CT tells me that I'm going to have tremendous challenges going down the main circumflex and the left main and the ostium of the LAD. It tells me that the ramus, which is the image on the right and the bottom to the left, is fairly free of calcium. And if at all, the calcium is very fragmented. So it's not going to be the problem at all. But the distal left main, as you can see on the image to the left and bottom, is going to be an issue. So the question now remains, is that going to be something that requires just rotational atherectomy, or would it require more? So the plan, the issues are going to be ongoing circumflex, whether it's significant in terms of size, the origin of the OM. Do I need a rotational atherectomy? How do I plan it? Would I need 2 or 3 stents? And should I consider OCT or IVUS? The way I look at it is I draw this kind of a cartoon, which helps me understand. And after the rotational atherectomy, you can see that we've ablated the plaque, we've made room, and then we run our IVUS images from the circumflex artery and from the ramus artery over there. And these are the image sections that we are going to rely on to make these choices for us. When we look at those images, they represent those images or those areas. Basically, angiographically, it appears that that ramus may not have a problem. And the question is, can I just leave that alone and not have to stent it? Or should I get involved in a complex bifurcation stenting with the circumflex at that level? Now, we know that the distal circumflex was 2.6 and a 2.9 from these images. So both these arteries are of fair value, in my opinion. And then you look at these bifurcation lesions over there, and it tells you that the OM branch has circumferential plaque. And here, very like rare occasions, we find that the carina of this bifurcation is involved. If we end up putting a stent in any one of these arteries, the branch is going to be occluded because there's going to be some carinal shift and some plaque shift, both happening at that area. This is important knowledge, which means that with these images, it becomes a 2-stent strategy. This is the ostium of the circumflex. It looks fairly tight, but with most of the calcium having chiseled out, it looks like I don't have much to deal with there in terms of calcium. This is the OM, and the question was, can I get away with a short stent in that ramus? No, that's a huge plaque burden for a short stent, and a good landing zone is only going to be there if I put in a longer stent and reach it to that point there. So the pullback from the LAD is going to be now important and crucial, and this is from the LAD to the ostium of the left anterior descending artery, and you can see the MLA is 3.0 at the ostium. And if you can see the calcium layout, it's like 2 sheets of calcium, one from 9 to 12 o'clock and the other from 2 to 4 o'clock. For me, these are still dilatable by standard balloon techniques or high pressure balloons. But as you come into the distal left main, you can see that there's 2 sheets of calcium which are fairly rigid, and these could be very strong. From my CT, I know that this is a very deep calcium and a very large, thick sheet of calcium. The proximal left main is a good landing zone to lay the stents. Here we use our IVL technology, and this is where 7 into 10 pulses at this area. What is important for you to note is that we used almost 70 pulses to kind of get this lesion expanded, and then we used a flextome to expand it further at 16 atmospheres. And that is how we show you the crack. This was an IVUS done after the shock wave before we put the flextome. And that is what that's the image where you can see the crack. As you can see the image on the distal left main, we have created a crack even on the bottom sheet. It was then simple. Our stent plan was 1, Then the second would be a culot. Into this, we do a pot there, expand it, and then lastly, we would then expand this, and then we get on to the next. So having done these two steps, this is our last step of putting in a stent as a double culot or series of culots, which is how we plan this case. And once we had made this happen, we had to reinvestigate how our IVUS was doing. And you can see that at this distal reference, 5.5 was our target, 5.6 was our target. We achieved 4.9, which is fairly good. At the circumflex over here, the only image that showed was the ostium of the circumflex. We had to kind of go up in those images. All were satisfactory MSAs, very well achieved. And this was the final angiographic picture, which makes us believe that, yes, we used the IVL technology correctly. The IVUS images helped me in two ways in this patient. My initial plan was to do a rotational atherectomy even from the left main into the LAD. But once I saw my IVUS images, there was an adequate lumen for me to kind of put in and place my IVL balloon, which is of some, like, it has a little bit of a profile, which can be a challenge sometimes. But here, I didn't think it was a challenge, and we were able to achieve this very well. When I look at the various images, this is the ones. When I look at the very left image over there on top, I see that it's a protruding small nodule. Most of these will, and if the wire is very close proximity to such nodules, you will see that the nodule is shaved effectively, and we are going to be able to get a good MSA for a stent position. When the arc of the calcium is less than 80, as you can see in the second image over there on the top, and there is an eccentric calcium with a normal segment of the artery on the opposite side, it is almost always a challenge. And in my current practice, this is a calcified image, which I really don't have a great solution for, because we don't have any laser, we don't have orbital atherectomy as yet in our labs. When it gets to a less than 180 arc of calcium with a large nodule, which is very protruding, those can be.
Your time is getting almost over.
Okay. So the only two is the last two images where you can see concentric calcium, like in the last two images, where IVL plays a huge part. IVL is not going to help in these calcified nodules. And the last is my regret from recurrence, where I wish I had IVL in my lab at that time. So for my calcified lesions, if it is uncrossable or difficult to cross, rotational atherectomy. Once I do a rotational atherectomy, it's image. If it's easy to cross, go an image. And based on the images, if I see a nodule or less than 80, then it's rotational atherectomy, as long as go up in burr size if the wire is close to the calcium. ELCA would have been great. Orbital atherectomy would be great. In concentric calcium with more than 180 degree arc, IVL would be a great option post, or you could outsize with a rota. And in ISAR with calcium within a stent, aggressive rotational atherectomy, ELCA, IVL may be an option. Thank you.
Kirti, it was excellent presentations, and you had wonderful cases, and I really enjoyed those, particularly the last one. Now, just to keep short, there are 2-3 questions are there, of which you have already answered in your cases. One is the IVL successful in treating the concentric lesions with a large vessel? Which you have already shown those 2 cases, so I think the answer is only yes. Because, see, this I'm doing it because we have to cut short the time.
Right. So I feel that IVL is probably the best technology to use for concentric calcium.
Yeah.
If you have a lumen enough to position that balloon there.
Yeah. Second thing is also, is it safe to do the IVL in the tight calcific distal left main when RCA is occluded, EF is 40 to 45%? The last case before you had shown where there was RCA was non-dominant, which was as good as not functioning, and where you have done with the IVL as well as rotablation. So I think that answers this particular question, but this was the question which was raised on the floor. The third important question is, OPN NC and shockwave both are used for the calcific lesions and both deal with intimal and medial calcium. And OPN, the usual story, the OPN NC is cheaper as compared to the IVL. So when do you decide that you want to do the IVL rather than going away from the OPN?
OPN is not for me. I've thrown it out of my lab. I don't believe in the technology because it's a sustained pressure at a very high pressure. And, you know, sometimes you need to go as high as 30 and 35, even though it's a little outside what is recommended. 25, 30 is what is recommended by them. But the problem is I've seen some disasters where the balloon starts elongating in one of the patients. The shaft of the IVL and the guiding catheter suddenly ballooned out. And So there are problems, and I don't use IVL. I'm sorry, I just don't use it. So in the current text, so sustained high pressure, whereas these pulsatile, it's only a 4 atmosphere anchorage for these balloons, and the pulses are 50 atmospheres, which are pulses, and they're not sustained. So they do much better because they're sonic waves. Yeah.
Yeah, I agree with you, because the focal pressure which is created by the IVL balloon is almost up to the 50 atmospheres, and it is a very focal and localized, particularly for these calcific nodules where it bursts. Anyway, I'll cut short here now. Kirti, thank you very much.
Thanks.
I'll welcome Dr. Suresh Vijan, because Suresh Vijan has to attend the SKY meeting at 5:15. Am I right, Suresh? So are you ready with your presentation there?
Yes, I am. Thank you very much.
Please go ahead. Kirti, thank you very much.
Thank you. Thank you.
Where am I? Share screen. Why am I going here? Here we go. Yeah. Okay. Right. Dr. Hawkins, Kirti, Dr. Makle, and everybody. Happy Independence Day, everyone. And it's been a nice presentation to listen to both you, Keith, as well as Kirti Purame. I'm going to present one of the first cases of IVL we did. Just ignore the title. The double vessel is just a misnomer. Come on. Yeah. This is a 56-year-old gentleman, long-standing diabetes and hypertension, as about 50% of our patients are. Recurrent angina over 6 months duration, gradually progressive. He had undergone a stress test, which is strongly positive at low workload. Then he went off to have a CT angio, which is good for us because it showed that it was heavily calcified LAD, heavily calcified RCA. And then he came to us and I said, well, with that calcification, we're going to have to use rotablator or IVL or whatever. And he was very much keen that we do an angioplasty only without even doing an angiogram. Didn't want surgery at any cost because I'm far too young. So that's his angiogram. Right is what I'm going to show because this is where we use IVL. That's LAD. Surprisingly, we actually thought we would probably use an IVL for the LAD, but the LAD popped with a straightforward balloon, and then we did OPN and finished the LAD off without any IVL. But RCA is where we actually use. This is the RCA. You can see heavily calcified, tight lesion up here, tight lesion down there, some lesions down here, and that's the RAO view for the same, showing it tight lesions. So we first passed the wire in and did an OCT. OCT has been a great boon, I think, to study what's happening. And you can see the OCT run here. Right from the time you get to this particular part of the lesion, heavily dense calcification, nearly circumcision in large portions of the artery. And across the board, where there is very severe stenosis also, you can see large chunks of circumstantial calcium all throughout. And when you come up here, that really looks even more nasty in terms of calcium. So here you go, all through, very nasty calcium. So clearly this was calcium, and surprisingly, the IV balloon passed. It was a 3 millimeter balloon, and we started treating this with 312 balloon here, and this actually 4 atmospheres anchorage, and then you could actually see the moment the pulses were given, the balloon started to expand as if that the artery was giving way. I thought, oh God, we're going to perforate. Then we actually treated the whole artery all the way up to the top. Same thing, and use up all the pulses for this particular case. Then we passed the OCT again. And that's the surprise of surprise. You can start seeing from here cracks in the calcium as you expect to see, and nice cracks telling you why the artery opened up. Calcium actually is broken up. And as you go further up into the artery, sorry, let's go back. Sorry, just a second, let me just go back. So what we saw was huge chunk cracks in the artery right through all the way up, and then went down with the 3 millimeter balloon NC. And the balloon just opened up, and the whole artery just got dilated with a 3 millimeter balloon without me having to resort to any high pressures at all. Then we implanted a 3548 Zions expedition. And that's the expedition. What's happening? Okay, that's the expedition 3.5, and then we post dilated with a 4 millimeter balloon the whole artery. We also put a small stent in the proximal area here, which was a 4/0 by 12, and the whole thing has been dilated. We then went in, actually did a post stent IVUS OCT. And there you can see the stents well opposed. You can see it clearly, absolutely widely open patent artery. And the artery is now looking like 3.54, which we never thought was there when we first started this, giving excellent center position across the whole port. Well dilated artery with no major issues at all, no perforations, no distal embolization, clear cut straightforward case. And the whole thing went off like a charm. So that's where I think IVUS made a lot of, IVL made a lot of difference in terms of making what was going to be clearly a very difficult case easy. We then, of course, dealt with the distal edge, which is not part of this presentation, put another stent there and took care of that, but there was no calcification there. So the final result was this. You can see this, very nice. This we dealt with later on. And you can see that open, well open artery, 4 millimeters RCA, which you didn't think it would happen when we first started doing this scale. So to me, where IVL help is actually getting the right kind of expansion of the stent where we deal with heavily calcified arteries. Here, in the olden days, I would have probably used a rotablator, but I have had some reservations of rotablator because we're only going to shave out a little bit of the calcium. What Kirti showed very nicely, the rings of calcium, which are all circumferential, can't really be touched by the rotablator unless you go up to 2 or higher, which is not necessarily something that most of us would do. So clearly, the procedure became a straightforward procedure in terms of using IVL, and actually we've got very good expansion. Cross-sectional area was good. Diameter was about 4 millimeter across the whole RCA, giving us a very good result. Later on, we put in another stent here, long 2.25 up to 2.5, we went and took care of that. So that's the kind of some sort of a very straightforward case which could have potentially been very difficult, but life made very easy by using IVL. Thank you. Dr. Makle.
Yeah, thanks, Suresh. It was a wonderful case. And actually, there was a pertinent question which was used, which was asked by somebody, that any tips and tricks to use IVL in the highly diffuse calcific lesion, which you are already shown in this particular case.
Yeah, I mean, that was some debate there actually, and I will be open to questions on that, because whether we should have done the whole artery that we did as with long stent, or I should have gone and put 2 discrete stents, one at the bottom at the tightest part. But that's open to debate. I don't really have a very good answer for that.
It's, of course, if you are already have got imaging guidance with the IVUS or OCT, you can decide where exactly you want to put this particular IVL balloon. Because it has got one problem, not problem, I'll say one limitation, that you have got only 80 pulses. So you have to use it, you have got a very limited finances. So
no, but actually, what we realize is that even the first pulse given at the tightest part of the lesion, the balloon just grew. So it works. I don't think you really need to hammer away at one particular area often, unless you find that it's not giving way.
You're talking the first set of pulse. It is a 10.
10, yes, that's right. Yes. First one set of pulses, which is 10. Yes.
So yes,
there is an interest in obviously having longer balloons, and there's also an interest in having more pulses. And as you will have seen, the peripheral balloons do offer more pulses.
Yes.
And we are looking at 3 different areas in the coronary: a lower profile device, longer balloon, bigger balloon, and also more pulses. So just keep watching this space.
Oh, good. Yeah. Now there is another question which has been asked: can the IVL be used for the instant restenosis?
I think there's a case after us on instant restenosis.
There is a case already there.
Let them answer that. Let them answer that.
Kirti, you can add to this if you want to add any particular one sentence, because we have to move for the next presentation after this. By the time we prepare, so I think the Milind Kharche is ready there.
So just one thing that if you look at the representative case that Suresh presented, which is awesome. I mean, you saw concentric calcium, and often in those you'll see that in the first train of pulses, or in the second, maybe in 20 pulses actually, that is 2 trains of pulses. Typically, most of these will crack.
Yes.
It's the eccentric ones, which are moving on to less than 180 degrees, that they may sometimes require 70 and 80 pulses, and they'll consume an entire balloon, and you may still not get it. The question is, if you are talking about a calcified nodule, then those can be resistant very heavily to even these, especially if a large part of the artery is normal on the other side.
And you'll get more data from CAD3 OCT because there are 100 patients. And also there's a German study, Holger Neff, looking at eccentricity. And eccentricity is obviously something that's very interesting. And is it as effective as concentricity? And this paper will come out and show some efficacy in eccentric lesions. And the nodules are probably something separate again.
Yeah. So Keith, I have a question, if I can kind of interrupt at this time. Keith, when we look at these eccentric plaques, I mean, I know that a colleague of mine ruptured even with ruptured an LAD with
Yes.
with an IVL, but I feel that I personally feel that the sizing of the IVL balloon is the key, and so. Is there anything you recommend in terms of undersizing these balloons for eccentric lesions, as in a concentric lesion where you think you want to get a 4 lumen for a stent? Would you then, if it was a purely eccentric lesion, undersize to a 3.5 or something?
I mean, we recommend a 1-to-1 sizing, and obviously the pressure, just as you said in your talk, I mean, the pressure, you're using it at low pressure, 4 atmospheres. Because all you're trying to do is oppose the device to the wall of the artery, not to dilate.
Right.
And so I don't think we have data to say yet whether you should undersize for eccentric lesions. It's something interesting, and we can certainly look at that.
Okay,
Question. In the CAD3, was it the eccentric nodules were treated with the IVL, or was there an additional device being used, like a rota? Or
There was no additional device used. So, you know, some patients in India particularly get rotor shock. There was no rotor used or other device, no CSI device in CAD3. So it was just balloon.
okay, and now we move on to the next speaker. Thanks, Dr. Suresh Vijan. I think you have to
Thanks,
catch up.
everyone. I got
And
it fresh.
I kept
Okay.
you in a time there.
Thank you. Thank you very much. Go
We
ahead.
move to Dr. Milind Karchak.
Yeah.
Are you ready?
Yes, yes, I'm ready.
Yeah.
Should I
please go ahead.
start?
Share your screen, please.
Okay. Are my slides visible?
Yeah, they are perfect.
Okay. So thanks everyone. So I got chance to discuss my case here on this platform. I'm going to discuss a case with a calcific LMC and LAD ostial lesion, which was treated with IVL. It was not only a technical case, but there was some decision dilemma also was there. So the patient was 70-year-old hypertensive female presented with alleged history of domestic fall, and she was diagnosed as a right intertrochanteric femur fracture with local hematoma, and her hemoglobin on admission was only 5.5. On the second day of hospitalization, she had chest pain with anterior STT changes. Her echo shows apical regional wall motion abnormality with ejection fraction around 50 to 55. She was having sclerodegenerative mitral wall disease with moderate MR, and her troponin were raised. So it was an ACS, intertrochanteric femur fracture, hematoma, anemia, blood loss anemia, and ACS, drop positive ACS. So obviously, immediately she received transfusion, HB went up to 8.5, and she was treated on standard ACS protocol with antiplatelets and heparin. And after that, she underwent a coronary angiogram, and this was the angiogram. So this was an PA caudal, and this was another projection showing almost 70%, 70 to 80% left main with, in the previous view, LAD ostium was around 90%, you can see. So now, as she already has one surgery planned for fracture femur, the treatment options were a bit difficult. So CABG options was discussed with the relative, but relatives and CVTS surgeons, neither of them were willing due to risk involved in that. Severe anemia, recent ACS, and another immediate surgery waiting were odds for the CABG. After a lengthy discussion, it was decided to go ahead with PTCA, as an orthopedic surgeon agreed to operate with antiplatelets later on. So actually we decided to do this case because it looks very calcific on angiography itself. So we planned IVL for this case, and I was not very sure whether she will tolerate IVL balloon inflation in left main. So I decided to pre-dilate it prior to that. And I pre-dilated it with 3.5 balloon. There was some transient hemodynamic instability at first balloon dilatation, and later on, within a minute, she gets stabilized. STs were resolved, and her blood pressure came up. And then after that balloon dilatation, I did in IVUS. This was a short run of LAD ostium and left main. So this was an LAD ostium, and this is left main. So almost 270-degree calcific arc at left main ostium was there. And so because she is going to need surgery and anything bleeding risk are there, so I wanted to be sure that there should not be any stained under inflation. So we decided to go ahead with Shockwave IVL. So even the distal left main size on IVUS was around 4, and the LAD size was around 3.5. But we decided to go ahead with 3.5 balloon, and we delivered 8 cycles of 10 pulses each at different in LAD ostium and LMC ostium. Here I means in between, I don't have the fluoro view of it, but the LM ostium was not inflated when I keep the balloon inside the ostium. So the last inflation, the last pulse or cycle I given with the balloon, 2 mm balloon outside the LM ostium, and then that LM ostium opened up. So this was an angiogram post IVL. This was post IVL angiographic result, and this is the post IVL IVUS after giving IVL Shockwave. So you can see that the calcium in the left main has been cracked, and it is at the ostium, it is deformed also compared to the previous IVUS study. So, but after that, when I again taken a check shoot, there was some narrowing in the proximal LAD. So I was not getting what it is. So I did an IVUS again, and to me, it turned out to be some sort of subintimal hematoma in that proximal LAD. So actually, initially, I was not planning to cover the stent up to that long into the LAD. I was just planning to cover a proximal LAD. But due to this, then I decided to take a longer stent from LM ostium to LAD. So that distal LAD was around 3.5. So I decided to stent it with 3.5 stent, and then dilate it with 4, and if required 4.5. So I just positioned the stent from LM ostium to the LAD, and it was 3528 DES, and I deployed it. Obviously, after the deployment at moderate pressures, is maybe around 14 atmosphere pressures, the left main is not optimized. You can see in the view. This was a stent boost of left main. You can very well see that left main is not optimized, but with a dilatation with 408 balloon, I can get a good result. So I need to dilate it up at high pressure, like around 22, 24 atmosphere pressure. But yes, I get a good result after that post dilatation. This was in a caudal view. Circ ostium was not pinch and flow was good. So I just left it there. And this was a post-stenting IVUS, and all ostial MLA, distal LMCA MLA, and LAD ostial MLA was good after post-dilatation. So we left it, and I didn't dilate with 4.5 balloon here. I just left after 4.0 balloon dilatation. This was coming in, And then this is LM. Yeah, you can see in left main the stent is well opposed. Some stent struts in the out of LM ostium. So after this procedure, after 3 to 4 days, patient underwent a fracture femur operation, and it was done successfully. And after 8 days of that, she was discharged from the hospital. And we, the orthopedic surgeon, operated with ongoing antiplatelets. So I just had that discussion I had with him prior to doing an angioplasty. So few take-home points, like Shockwave IVL is an effective in LM calcification to get an optimized stent inflation subsequently. It is less demanding as far as keels are concerned than rota, and effective in cases where lumen is good but walls are heavily calcific and may not yield to the balloons. So many times when you cannot put the balloon, you need to use the rota. But if your lumen is good and if you are able to put a IVL balloon, you may avoid rota in such patients. And it should be seen as a complementary technique to the rota rather than a competitor to rota ablation, because our implications of using rota ablations are going to change with availability of this technology. But we at times we will need a rota, and it's not going to go out of our counter soon. Thanks.
Thanks, Dr. Milind. It was a wonderful case, and actually you are more confident because your orthopedic surgeon was ready to operate on the patient with on antiplatelet agents.
Yeah, but there was no other option left.
There was no other option, I agree. But it adds some mental confidence while you are doing this type of procedures.
I did procedure on that term only.
Yeah.
Otherwise, I will not surgery.
Yeah, the second thing what you have said is absolutely right, that IVL is a complementary to rota, because see, there are certain situations where IVL balloon are not able to cross. So you have to do the first rotablation and then do the IVL, what is called as a rotatripsy, etc. I think there must be one or two other cases, or we have seen such type of cases. So it was a wonderful case, and it again explains that left main bifurcation or left main ostium can be done with this. So with this, now we move on to the next case.
Can I just say,
yeah,
very nice case, and there's obviously increasing interest in the use of IVL in left main. And as you showed, I think it's really important to always have imaging. You probably always have imaging for left main anyway, but either IVUS or OCT, both for planning and to assess the result, just as you did. And we're funding a study on left main. And finally, I agree with you that rota and IVL are often used or infrequently used together, but they are complementary. So if you can't pass the IVL catheter, fine to do rota first. It is a lot easier to use than rota, clearly, and the learning curve is shorter. Very nice case. Thank you.
Kirti, do you want to add anything?
No, I think that was exemplary. I think beautiful case, perfectly shown that the IVUS actually clearly showed a nice round calcium.
270-degree calcification there.
And the gutter where your balloon would lay will be adequate to crack that. But I guess just one thing, when you're getting into calcified lesions, I think we should not kind of move away thinking that we have now an alternative technology which will take us away. It requires a whole work of, you need to have a skill set of all the technologies that are going to be available in that space, because often we will need to move and shuttle from one to the other to get a great result.
Okay, now we move on to the next presentation by Dr. Ashish Agrawal. Are you ready, Ashish, there?
Yes, sir.
From the, yeah, please share your screen.
Good evening, everybody.
Hi. Good evening.
Respected expert panel and dear panelists, my dear friends. I will be presenting a case of in-stent restenosis. This was done last month by me and my colleague, Dr. Prashant Kharche. This was actually a case in which the stenosis appeared between the two stents, which were probably not overlapping. This was a 74-year-old patient, non-diabetic, hypertensive patient. He had an coronary event in January 2020, for which he underwent angioplasty to RCA. Now he came last month with, in the month of June, with 1 week history of new onset angina. It was NYHA class 2 to class 3 angina, and it rapidly progressed to quite severe symptoms. Even routine household activities were giving rise to typical chest pain. His ECG, echo, and troponin when he came to OPD was normal. So we took him up for angiogram. These were the left-sided shoots. They were showing some plaques in the left system, in the OM and in the proximal LAD. No significant critical narrowing on the left side as such. This was his RCA. So it was showing the fluoroscopically visible calcium, tight stenosis in the mid segment, which was probably between the two stents. This is the RAO view. And there was TIMI1 to TIMI2 flow. This is the fluoro image, which was showing some under expansion of the proximal stent probably, and a space between the two stents. So basically looking at this RCA, we thought probably it is not so bad looking RCA, maybe an innocent kind of RCA, which we should be able to do with one stent. And in the lockdown period, we thought probably it would be a quick job. But then we had a good fortune to talk with the previous operator. So when we had a word with him, it was very clear that it was a long case when he did the case. There was a lot of problems in delivering the hardware. He had to use two stents. He initially planned for one stent, but because one long stent was not going, he has to use two stents, 3/18 proximally and 3/8 distally. And he said that probably use them in an overlapping fashion. After that, patient remained asymptomatic for 6 months, only to land up with symptoms again since 1 week. He was on aspirin and ticagrelor. So with this history in mind, we were sure that we probably will not be able to get away very easily with this case. So we planned the case. We thought that we will need a good support. So we planned for Amplatzer guiding with femoral root, and kept Guidezilla and Grand Slam wire ready if we need it. And because it was a case of previous stents implanted with a lot of calcium, we decided that we will use imaging. Fortunately, we had access to OCT at that time. And then for debulking, we thought of IVL balloons, and we gave a thought to rotablation. But because of the recently implanted stents, we thought probably it will not be a very nice idea to use rotablation in this case. So these are the shoots with AL1 when we started the procedure. We crossed with routine workhorse Renato wire. The crossing of the lesion was not a problem. Then we did first dilatation with 1.5/12 mini-trach balloon. The balloon ruptured at the end of the first dilatation, as we can see with the diastema going down. After that, we took a larger balloon. This is the stent boost with the balloon across. We can see there is clear gap between the two stents, and probably under expanded distal portion of the first stent. So we dilated with this balloon. The balloon opened up quite nicely fluoroscopically. In the proximal portions also, there was significant recoil even after the balloon was opening up nicely. And once the balloon opened up, there was difficulty in recrossing with the same balloon across the lesion, as we can see in these loops. Our guide was backing up when we were trying to cross with the balloon. So we decided to take a larger balloon before going for any imaging. Before that, we took a buddy wire. We took a Grand Slam as a buddy wire, and with the help of that, we were able to cross a larger balloon across the lesion. Although with some difficulty, we were able to cross the larger balloon and dilate it. So with 3/12, we dilated this portion. Again, as we can see, the balloon is opening up quite well fluoroscopically in this LO view. And then we did proximal dilatation with the same 3/12 NC balloon. After this, there was an untoward event. Patient suddenly went into bradycardia and hypotension. He, in fact, required a short CPR also at this moment. We were not sure what exactly happened. Probably it was spasm of the RCA because of the balloon dilatation at the ostium, or probably some sucking in of this AL guide, which caused sudden stoppage of the flow across the RCA. So we removed the balloon. The one wire came out. Patient fortunately stabilized after a short CPR and atropine. We put in a temporary wire after that. And then, because we had done dilatation with 3O balloon, we thought we will now go ahead with OCT. But to our surprise, the OCT catheter was not crossing beyond this point. The guide was again backing up, and OCT was not going even after 3O NC balloon dilatation in the same area. So after that, we decided that we will go in with the GuideZilla. And with the GuideZilla, we decided that we'll probably not go for imaging now. We'll probably directly go for IVL, because the patient had become unstable after that previous event. So we were a little keen to do the debulking first. And the debulking device which was on board was an IVL. So with the help of GuideZilla, we put in the IVL balloon as far as it could go, and then delivered 2 sets of 10 pulses each at this region. Our GuideZilla was not crossing much deeper beyond this lesion. After this IVL, we were able to cross with the GuideZilla and reach close to the lesion site. There we were able to then deliver IVL across the lesion with the help of GuideZilla. Here we gave almost 5 cycles of 10 pulses each, around 50 pulses, with the anchorage of 4 atmosphere. This is the RAO view, which is showing decent balloon expansion. Decent balloon expansion was also seen with previous NC balloons as well. So after this, then we were able to pass the OCT catheter with the help of GuideZilla support. So this was the OCT picture. So it was showing distal stent, which was 3O size, which looked like adequately sized stent, well expanded. This is of course after balloon dilatation. And the distal reference vessel was around 2.75. Here it was a 3O stent. And this was the problem area, which was the narrowest portion between the 2 stents. It was showing some eccentric calcium, probably a spur-like thing somewhere in the between 7 to 9 o'clock position. This was post IVL. We were also able to see some cracks in the calcium, and this was the narrowest segment. And after that, the proximal stent was also adequately sized. It was a 3O stent. Sir, do you want me to play the OCT again, or is that okay?
Yeah, I think you play it once again so that we can go through those images.
So I'll play the entire run.
Yeah, and show that calcification, which is actually 7 to 10 o'clock.
This was the distal stent. This was the tightest portion.
Yeah.
And these are probably the cracks that we can see.
So actually, the stents were not overlapping. There was a
not
gap.
Overlapping. There was a portion which was.
It may be possible that the previous operator, while deploying, he might have deployed, or it might have sort of migrated because of the continuous movements.
Probably there was this calcific eccentric calcium which prevented the stents from, or any hardware from going in.
Yeah. Okay, I think go for the next.
After that, we again went in with the IVL balloon and delivered the remaining pulses at the same spot. Remaining 10 pulses were remaining, so we delivered it at the same spot. Following that, we did dilatation with high pressure dilatation with NC balloon, and these are the shoots pre-stent implantation. They were showing a fairly adequately prepared lesion in this LO view. In RAO view, also it was showing an adequately prepared lesion, except maybe there was still some, if you can see in some views, there was still some narrowing at that tightest portion. So we went ahead with the stent at this moment. We decided that we will probably cover only the problem portion first, the distal portion first. We chose a 3x24 expedition stent. The distal stent was adequately sized and was properly opposed. So we were okay to end in that stent after covering the proximal portion. And we decided that we will have a look at the proximal RCA after optimization of this stent. So this is the stent boost before the dilatation of the stent. Here we can see the distal stent as well as the proximal stent is showing opened ends here after the preparation. We went at 16 atmosphere to dilate the stent, to open the stent. After that, we took a 3x10 NC balloon and went at 26 atmosphere slowly for post dilatation. And following post dilatation, we took that balloon little up, and in the previous stent we did dilatation at around 14 atmosphere because there was a lot of manipulation with the guiding at this proximal portion. We did a nominal dilatation here, and this is the OCT run post stent. It was showing very good fluoroscopic picture. If we look at the OCT, distal and proximal portions were fine, but again the problem portion, which was actually the issue, it was still not showing a very good lumen area. So the lumen area that was calculated at that site was around 3.65 millimeters square, which was not very great. However, it was a short segment, and proximal and distally stent was looking okay. Fluoroscopically, angiographically, the result was looking okay. You want me to play the OCT again, sir? This one?
No, I think it is a self-explanatory. We can go for the next slide. The stent is opposed
Right.
well. It's almost wide all across.
So we
Only thing is
decided
to post dilate again there.
So we decided to stop there, sir. We went at almost 26 atmosphere pressure in the same area.
Okay.
We waited for 10 minutes and then we decided to take check shoots with JR to see for the proximal portion. These were the final angiographic picture. So we stopped at this moment. We thought of using OPN there, but then because of that eccentric calcific spur and already having delivered almost 60 pulses with IVL, we decided against it.
And one arrest in between.
Yeah. So there are a number of learning points from the case. We probably would have used 7 French guiding. We used 6 French. Use of guideliner upfront would have probably shortened the duration of case. And we could have used a balloon tip pacemaker at the onset because we were anticipating a difficult RCA. However, talking with the previous operator and getting to know the previous history definitely helped us. Otherwise, without the preparation, probably would have been in a lot of trouble. Some questions that I had is because we are still not at the appropriate lumen area, he probably carries risk of restenosis, and what would be our options in that case scenario? Should we have used high pressure OPN in this case after we did the final OCT? And should we have used rotablation in this case to achieve even better results? So with that, I finish my case, sir. Thank you very much.
Yeah, thanks, Ashish. It was a really wonderful case. And actually, we have already pointed it out that it was not the overlap of the stent, because it is the previous stent is not telescope, as you could clearly see in the OCT as well as in the stent boost also. And that was the part where there was a heavily fibrotic and calcific, and maybe possibly the previous operator could not pass that stent, the proximal stent, could not telescope into it. So Yes, the other thing is about your question whether the OPN could have been used. I still feel yes, the OPN could have been used after the now it is third stent what you are deploying. OPN could have been used here to dilate because the area of cross-section area there is 3.63, which is a relatively low. So I think you should have used OPN. But of course, with the one arrest in between and all these things, etc., you want to sort of have the safe patient, even if the patient is available for the next procedure. I agree with you. The rotablation for the ISR is always a big question mark. You can use the rotablation if it is showing the neointimal hyperplasia, but otherwise you can ablate the entire segment of the, if it comes in contact with the stent struts, it will create the gravel which is of more of metal rather than the tissue. Kirti, do you want to add anything to this, what I'm saying?
So,
This, of course, this was was a case of, it wasn't a case of ISR, it was a case of narrowing between two stents, which were not overlapped. Many of you will have had an opportunity to use IVL for ISR, which, as you know, remains off-label. And there's a lot of interest in this area, but of course it depends a bit on the timing of when you're intervening. Because if the stent is not endothelialized, there's concern about what the IVL is doing to the drug, the polymer. There's evidence that it can pit the alloy. And so it's an area that we need to understand more about. There are quite a few series now, either about to be published or in the literature, including one from France. And it is an area of great interest because obviously these patients, if you can't get a good result, then the patient ends up often with a CABG. So more to come, I think. Nice case.
Kirti, do you want to add any point on this?
I think the real issue here is in these calcified lesions. One, I think positioning the stent, even when you dilate these stents, putting a new stent in is not easy. So I think you answered some of your question. The question I really feel that is relevant to this case is if your NC balloon is able to fully expand at 3.0, then for me, there isn't much room to then use an IVL because we've got full expansion with that stent, really. So it doesn't make sense. My real problem with this is, and this is something I see all the time, is when you're looking at these gaps in arteries and you put in a 3.0 artery in such a right coronary artery, many a times we might be undersizing that artery because unlike IRIS, a lot of our focus with an OCT imaging is entirely on the lumen and we don't look at the vessel wall. And it could be very obvious that if you put in an IRIS catheter, you'd be surprised that this could be a grossly undersized stent, even the 3.0. And this artery may be more deserving like a 3.5 stent or something like that. And I, at this point, and once you have these two stents in place, can you do a rotablator? Yes, you can do a rotablator. We've done rotablators for unexpanded stents. We've done rotablators for shortly expanded stents, as well as for TLRs, which have come in after 10 years with calcified sheets within those stents. Those rotablators have to be done carefully, but yeah, it can be done if that's the case. And the rotablator doesn't really go and ablate those and make a metallic gravel or anything. But yeah, sorry, you were saying something.
Sir, what about rotablation in recently implanted stents?
Yeah, so we've got around 12 or 13 such cases where unexpanded stents, and we've put in rotablator. For ones which are ones which come in late, that means they come as an ISR. There, it's okay. You can easily do it. The question is if you're in an unexpanded case which is recently performed, then I think you've got to be careful because one of the biggest problems of rotablatation in that group is a stuck burr. So you've got to be very, very careful in terms of how your wire is. You've got to make sure that your wire is not gone through the substruts anywhere. So you need to have an image. You need to make sure that your wire is completely in the lumen. And then if you you choose a moderate kind of burr, you can't push it. You've got to be very gentle in terms of allow the burr to go and do it. Very often we've realized that even by just being at a burr, even if the burr doesn't cross these stents, it heats up the metal enough that it actually chars that tissue. And then you go back with a balloon and the balloon cracks that lesion because temperature wise, it has altered that tissue to some extent. And we've had 3 out of our 6 cases have expanded even without crossing the burr. But I mean, that's a separate issue. I really wonder what was going on with you in terms of thought process. Why did you choose an IVL here? When
Sir, the reason was that nothing was...
When you were able to expand your 3.0 NC balloon completely. And I need Keith's view on that. Is there a role for this? Is that like lulling us into a false sense of security that, okay, now we might have a better result? I mean, what is it?
Sir, basically nothing was going inside that artery even after a 3.0 dilatation. That was one reason for going to IVL. Even OCT catheter or even a balloon which has already expanded was not able to cross again. So what I feel is that the IVL delivered little proximally in the area made some difference for easy passage of the hardware, of course with the help of guideliner support that time. But that was the reason for using IVL, because we were not able to cross. So we thought there is something inside, some eccentric calcific spur or some nodule which is preventing the passage of anything going inside. So that was the idea behind using IVL.
Okay, okay. Keith, would you kind of, is this an area that you would have a comment on specifically with the question that I have is, if an NC balloon is expanded completely, 2 orthogonal views, you see complete expansion of that balloon, then would there be room to still exercise with an IVL balloon? Will it achieve any more than what that balloon has achieved in the first place?
I think it all depends on the compliance of the vessel. So if you've got a fully expanded NC balloon, what you don't know is the compliance of the vessel when you put the stent in. And of course, you can't tell that until you try. So I do think IVL may have something to offer, but it's very difficult to judge whether it's going to give you additional benefit over and above the NC balloon at that late stage. But it might improve the compliance of the vessel if it's heavily calcified on imaging.
Okay, with that, I think we'll stop the discussions here and we'll proceed for the next case presentation by Dr. Sunil Vani. Are you ready, Sunil?
Yes. Give me a minute to share.
I think this entire case could have been done with the OP and NC alone. What do you feel, Kirti? No, you are muted.
What? Oh, I'm okay.
Yeah,
so I feel his problem whenever something is intrusive to kind of passage of devices within the lumen, that means there's a projecting calcified nodule or something. And I think that a rotational atherectomy smoothens that out well. Let's go to this case. We can, if we have time. We
can you see it now? Can you see my slide?
Yeah.
You can hear me also. Okay. So this is a 63-year-old male patient, had an anterior wall MI, underwent a primary PCI in 2014, which I did, and he has been fine, stable, and the last follow-up was a year back. And now he had an ACS in March 2020, and we did an angiogram, the RCA, I'll just show you. The echo EF was 35% with inferior hypokinesia, TROP was positive, the creat was 1.2 with CC creat clearance, 59 ml per cc. This is the angiogram. There, as you can see, the RCA is tortuous, calcific. This is the LAD stent, which was patent. So here I would like to ask our panelists and the chairpersons that with this RCA, which is tortuous and calcific, definitely rotablation becomes risky. And I think many must have done rotablation still in these situations, but still one would definitely have in the back of the mind that use a smaller burr, like 1.25, you can get a stuck burr, and if you use a bigger size burr, you can perforate.
Okay, I agree with you. It is going to be the challenging, but now with the availability of the IVL, it makes your life easy. In the yesteryears, yes, we still would have done rota when the only rota was available.
Yes, I think that was the only. So we used the AR2 7 French BMW. Rota versus IVL was the thinking process here, and keep the rota anyway backup, because if the IVL balloon doesn't go, then you would definitely be in a mess. And it's because the left is absolutely fine, the stent is fine, so we're committed to treat this artery. And so we went ahead with the 2.512 NC balloon. The balloon crossed with difficulty, and I'd kept the 6 French Guidezilla backup ready in case if the IVL balloon doesn't go, then would go close to the areas, the calcific areas, and try to burr with the help of Guidezilla support, and not really go completely drilling across with a burr. So here, as you can see, it's a little longish run, but I want you to have a look that the 2.5 balloon was backing my catheter out, and with difficulty it went in. So we had not much option but used a Guidezilla right away. And with the Guidezilla support, you can see that the 2.5 tried creating a little channel for my IVL balloon. And I was lucky to have the IVL balloon down. This is a 3012, and this is post. But we had, after the 3012 balloon, the balloon distally, when we used it first, there was a pinhole, as you can see here. And so we thought that the proximal artery is 3.5. So we went ahead, we took a 3.5 12. The 30 balloon had already delivered 30 pulses. And we went ahead here with the 3.5 12. As you can see here, the proximal calcific segment, it really did give away well. So we used the pulses distally to proximal. This is the final angiographic result. So distally 20 pulses with a 3.512, mid 30 pulses, and proximally 30 pulses. This was the 3.512. So send delivery also was definitely a problem, and required the Guidezilla support to get the stent down. This was the first stent, this is the second stent. You can see the guide was completely backing out, and so post delivery of the stent also, we had to use the Guidezilla to get the post dilatation inside the stents to support the post dil balloon inside. And this is the final result. So the take home message here, I think in tortuous calcified arteries, rota is risky, but it's not that we have not done it earlier, but it has to be carefully done with short pecking movements. And so you can have perforations or you can have a stud burr. So shockwave, if deliverable, obviously with support, with the most important thing in this is to ensure you have good support to get your IVL balloon down. Here we used Amplats catheter and then a Guidezilla, for to get the IVL balloon down. And the IVL balloon, we had a rupture, might be a possible eccentric spicule. We've not done imaging in this case. And so maybe that could have thrown more light as to why the IVL balloon did rupture. And then we kind of oversized the IVL balloon. We used the 3.5 even distally. So we don't know the long-term outcome in that. And the guideliner is a requirement as I would like to harp upon. And it also helps us to get our rotablator device inside in case if we do not succeed with getting the balloon down. Thank you for your patient listening.
Excellent case, and it was actually a tough call because you had calcific vessels, severely tortuous RCA, and I agree even the rotablator also could have some problem. And the cause of your balloon rupture, I feel there must have been a calcium spicule or calcium spur which has ruptured at that particular moment. And obviously, so whatever and you did not have an advantage of intravascular imaging, so really we can't comment on that, what exactly it was. But conjecturally, it looks to me that there was a calcium spur which has ruptured the balloon. But nonetheless, you did manage the case very well. And it shows that IVL is a little better proposition as compared to the rotablation, because there is always a fear because of the guide wire bias, you can have the perforation in the calcific tortuous coronaries. Kirti, do you want to add anything on this?
Not really, except for the fact that it's not such a bad case for a rotational atherectomy as far as...
yeah, we would have done it. That's something.
We've been doing these every day, and it doesn't have like multiple right angle bends, which can become an issue. But yes, I understand that when you're not doing it as frequently, probably the rotational atherectomy is a little less forgiving, and therefore, if you have an alternative technology which will then make it simpler, then I think you're okay. I think the only problem we could have had is if it did not cross, then what? And if you made a partial dissection in that tortuous artery, then even falling back as a second step to rotational atherectomy becomes a little more challenging.
So, I ask you, would you upfront go with a rotablation in this case than an IVL?
I personally would have gone.
So in the patient, in the patient that you showed me, Sunil, in the patient that you just discussed, I think my first choice would, there's no question that my first choice would be a rotational atherectomy, because remember, the IVL balloon is not a very low profile balloon, and you have to push it past with a Guidezilla, which means that sometimes you're anyway, I'm not even sure if by doing that, you're traumatizing the outside of the balloon, which actually led to the rupture probably to some extent. We have seen this happen with normal balloons. When we try to push very hard in calcified lesions with Guidezillas, they rupture at lower pressures than they would otherwise. So I'm not sure. I mean, Keith can probably answer that question, but I think it shouldn't change your threshold to do rotational atherectomy.
So what burr size would you use? 1.25?
I never use a 1.25. I don't use I mean, I wouldn't say never, but it is always a 1.5 is a standard workhorse burr, even for these. Yeah.
The proximal bend was really like an omega, so I was worried that 1.5 would be a worry. So I thought that might as well use something which is safer. And
I think you did a great job.
See, you did it good, but as I said, that I also would have done the rotablation for this case. The only trick here while you are doing it, you should advance it very small. The small picking, take a small
Don't push it.
segments. Don't try to cover it right from the beginning to the mid of RCA. Do it step by step, wait, let it align again, do it again, no problem. You may take extra runs, doesn't matter, but you can do it.
Makle, I call it the coffee rota. That means you go, do a run, come back, have a sip of coffee, go back, do a second run, and things like that. Yeah.
Kids, do you want to add anything from the IVL side? Now you have to defend it.
I think, I think we recognize balloon rupture even with ordinary balloons in heavily calcified vessels.
Right.
And we modified the material that the IVL balloon is made from to reduce the chance of rupture, which is currently less than 5%. And I think your point is well made. I mean, in most of the studies, about 50% of IVL cases require some pre-dilatation with a small balloon to get the device across. There's a lot of kit in the balloon, so it's not the lowest profile balloon, the IVL balloon. Although we are developing a new device, which we're calling internally the Mini, which I think will interest you, and that's in development. But right now, you should anticipate that about 50%, if you can get an IVUS or an OCT catheter across, then you're going to get IVL across.
Okay.
But you may have to use a 1.5 balloon to make a passage.
Yeah, Ashish wants to ask something. Ashish,
sir, if you have to do rota in this case, would you straight away go with the GuideZilla pin, or you will try with the guide?
No. You can't go with the GuideZilla.
So
Start with the 7 French guide catheter, do the rotabulation complete. Then, if necessary for transit of the stent, etc., if you need a GuideZilla, that's okay. But otherwise, no.
So the only RCAs where I have used a GuideZilla and done a rotational atherectomy through a GuideZilla using a 1.25 burr alone is the shepherd crook. When there's a shepherd crook, like almost a hairpin bend on the RCA, you need to protect the lesser curve of that artery because your rotational atherectomy catheter or the wire and along both the systems together exert a huge pressure on the lesser curve, and they almost become ablative, and you can create a neolumen in that area leading to rupture. And I mean, I could show you multiple cases. So what I do is I go past that curve and park my GuideZilla so that my catheter is my rotablator is well within that. But the only limitation to that is then you're forced to using a 1.25 burr. That's it.
Yeah, but Kirti, you have to add one more point here, that while you are advancing the burr, don't go on a Dynaglide mode. You have to go directly with the burr. If you go on a Dynaglide mode, you will snap off the junction of the proximal end of the GuideZilla with the wire there.
So the rotablator can become a topic by itself. I think we're considering the IVL today. So let's have any questions more about the IVL because Keith is.
Okay. So let us go to, I think Dr. Rohan is waiting for his presentation.
Right.
Rohan, are you ready with your presentation? Rohan?
Yeah, are the slides visible? Hello. Am I audible? Hello.
You are audible, yeah.
Yeah. So are the slides visible?
They are.
Yes, please.
Yeah. So I'll be discussing the case of, as the topic goes, of IVL, but it also required an OPN balloon for final expansion. So my case is a 62-year-old male, non-diabetic, non-hypertensive, and he presented with a very recent onset crescendo angina of almost NYHF function class 3 over past 10 days. His ECG was, baseline ECG was essentially normal. Echo was normal. So we did a treadmill test and it was a very strongly positive treadmill test with an ST elevation within 50 seconds in the precordial leads. So this is his baseline ECG. And this was his angiogram. So as you can see, it's a heavily calcified vessel in the mid part and some calcium specks in the proximal part. So working in a peripheral center as a single cardiologist, I don't have the luxury of doing an IVUS in the vessel, but looking at the angiogram, I never planned to do the case at my center. I usually refer all the calcified vessels to a higher centers where you have all the equipments at hand and CABG bypass at standby. So this was his angiogram, but because of the lockdown with a syntax score of 15, we have to take up this case at our own center because they were not willing to move to a higher center. So hearing about IVL and all, so we planned the case with a very low skill set required. We planned this case to do at my own center. The RCA was normal. So this is a single vessel disease of LAD with a heavy calcification in the mid part and a moderate amount of calcium in the proximal part and a long lesion. So the plan rotablation was out because we don't have it at our center. Cutting balloon, shockwave balloon, intravascular lithotripsy, or refer him for CABG later. But he was truly symptomatic with NYHA function class 3 to 4 angina, and he was having recurrent rest angina. So we planned this case and planned right up front with the plan of going with the IVL balloon. So as usual, wired the lesion, pre-dilated with 2.5 balloon, sapphire balloon. And it was showing some waste. It didn't expanded great, but it made a room for IVL balloon to cross. So post-dilatation, this was the shoot. There was a heavy chunk of calcium in the mid part, as you can see. So after pre-dilatation, we chose 3.5, 3 into 12 IVL balloon and delivered 30 pulses in the mid part of the LAD and 30 remaining pulses in the proximal part of the LAD. The proximal yielded well, but the mid part of the LAD didn't expanded that great. So post IVL, this was the check shoot, and I thought we have prepared the lesion as we didn't have an IVUS, so didn't had a imaging on that vessel, but looking at the angiogram, I thought it will yield well to the stenting. So the mid part of the LAD was stented with a 3 into 24 Yukon choice flex stent. It was deployed at 14 atmospheric pressures for 20 seconds, and it expanded. But to some extent in the mid part, it had some residual waste, which you can see in the check shoot, and with some recoil of the stent. So that was the area where it was not yielding. So we did we used the second stent, completed the entire length of the LAD. The second stent was 3.5 into 18 mm Yukon choice flex stent. It was also deployed at 14 atmospheric pressures for 20 seconds. So this was a check shoot after the second stent. So as you can see, there was a waste after the diagonal. So we had to post-dilate that lesion. So we took an NC balloon, 3 into 15 mm, and dilated at up to 22 atmosphere. But still there was a residual waste. So I was not very happy with the result. I thought there would be increased TLR target and chances of high chance of instant restenosis. So to yield to the waste, I used an OPN balloon, 3 into 15 mm OPN balloon, and dilated almost up to 40 atmospheric pressure because it was not yielding below 30 atmospheric pressures. So at 40 atmospheric pressures, it yielded well, and there was no residual waste after that dilatation. So this was a good result, angioplasty with a heavy calcium with the help of an IVL balloon. Looking at the caudal view, the proximal LAD was also showing some residue. I think the stent had expanded in an oval manner, so the caudal views were showing some residual waste as compared to cranial views. So it was also post-dilated with 3.5 into 12 mm NC-TREC balloon at 22-4 atmosphere. But still there was a residual waste. And for this also, we thought we'll use an OPN balloon. So I used a second 3.5 into 15 OPNNC balloon and dilated up to 35 to 37 atmospheric pressures. And this was the final result, which was, I think, excellent result, given a heavy calcium in the mid part. So not great take-home message, but availability of these advanced techniques at peripheral centers makes our life easy, and newer hardwares make PTCA much more comfortable. Like these heavily calcified vessels I would have never attempted earlier. Leaving the residual waste can cause higher incidences of ISR and repeat procedure, as the case we saw earlier, that between the two stents he had a severe ISR. So plaque modification by various methods is must for good result angioplasty. High-end balloons like OPNNC cutting balloons should be available on the shelf for rescue measures. Thank you.
Yeah, Rohan.
Yeah. Good evening, sir.
Yeah. It was a good case. And as you have already highlighted, that we should have everything in the armamentarium, and particularly in the COVID season.
Yeah.
It was, I'll put it other way around, that the opportunity has come to you where you could do justice to this patient, where you need not to refer it to the other center.
Yeah.
So congratulations for that. Kirti?
I have only one message for peripheral centers in our country. I think whenever we take on these cases, make a plan and try to accommodate and make sure that before you take the patients on table, try to envisage everything that can go wrong. And you should have a plan B and plan C in place, because when you start off these cases and you start getting into trouble, then, you may not have everything that, Dr. Makle has in his lab or I have in my lab. So just try to think it through. And sometimes it might be good to even talk to some people who are doing it more often and get advice. But I think you did a great job. And I commend you for being able to take this and pull it off. And these technologies will help you. But you need to have
which was available.
Always.
So that only encouraged me to take up this case.
Good job.
Discuss this with the earlier seniors present in Nagpur, and then only we go ahead with this case.
Very well done.
Thank you. Thanks a lot.
Very well.
So I think all the presentations are over. Everybody has done a great job. And I must special thanks to Dr. Kit Dawkins and Dr. Kirti Punamya to show their presentations. Kirti has shown the exemplary cases. So I think the only problem with this, everybody starts copying Kirti, then it will be difficult. They will land in trouble. So that's how the Kirti stands out apart. And I must give congratulations to all others, compliments to everybody, because in their own environment, they have delivered the best. And what is more important is the thought processes, what you need to go through. Suppose in case like the RCA has, that particular patient has arrested, but you continued with it and you did the complete job. So you have to be with your head on your shoulders and do all those cases, because patient safety is the most important. You should have all the armamentarium available. Is easy to say, but it may not be possible in a peripheral center. So whatever is the limitations are there, but always think of alternative plans and be ready with that. And I think we have finished all presentations. Dr. Kit, do you want to make any comments?
Well, I thought it was a great session, and thank you for your excellent sharing, wonderful cases. And we're all looking forward to coming back live to India again as soon as COVID departs. So well done, everybody. Great technology, great skill, and very nice. Thank you.
Okay. Shall we close the sessions, or there are any questions?
No, I just want to thank you, Makle, for being there and so beautifully anchoring all this. It's a joy to have you and speak with you and have you.
Okay. Thank you very much. Have a great evening.
Safe.
And be safe in the COVID era. And as Dr. Kit Dawkins said, that we want to have the more of the live cases on the forum, on the theater, rather than this virtual. Because there we can meet everybody in person. Thank you very much. Thank you. And thanks Trans Illumina for organizing this. It was a flawless. It went off well. Pankuri, thank you very much, and entire other support team. Thank you.
Thank you so much, everybody,
And we
for
finished in time.
participating in the session.
And
So
finished
we
in
will
time.
be going on the next session, which is on high pressure plaque modification. So stay tuned with us. We will be starting the session within next 10 minutes.
Okay, fine. Thank you. Thank you.